So if you just join, I would like to say welcome. You're watching the official commemoration of World Pharmacist Day. This is being commemorated at the Ministry of Health in collaboration with the Pharmaceutical Society of Liberia. And we are at the Ministry of Health, where we are to have an indoor program commemoration of this day. Shortly we will be shortly we will speak with some of the pharmacists to tell us a little about this day.
All right, ready? Yeah. Ready? D-Hub. All right, thank you. Sign
And this year's celebration is under the theme Think Health, Think Pharmacist. Held on this 25th day of September 2025 by the Pharmaceutical Society of Liberia. On our table, in our table, we have the President of the Pharmaceutical Society of Liberia, Dr. Joy D. Kakula. We also have the Chief Pharmacist of the Republic of Liberia, Dr. Joshua T. Peters. We have our honorable keynote speaker, Dr. Catherine T. Cooper, Deputy Minister for Health Services, the Chief Medical Officer of the Republic of Liberia. We have our Registrar General for the Liberia Pharmacy Board, Dr. Memo P. Dona. Also on the high table is the Managing Director of the Liberia Medicine and Health Product Regulatory Authority, Dr. Luke L. Bell.
And I'm the master MC at the MC. We'll change the protocol a little. I'm going to do. We'll call on our Honorable Director of CSM. So busy. Oh, we are glad that he came in. In fact, we thought that he was trying to contribute. Some of the work to that for God will do it on the program. Say now yet. But we are glad. When I saw that, I said,
Thank you so much. Thank you. What a good way to give an excuse. Yeah, but you know I'm always ready, always available, and I don't want to commit any academic or professional crime, and so I seek your indulgence to permit me to stand on existing protocol to address you great people. Today is historic. In our country, this celebration is unusual. This is not random, where we just come into the hall and people just make speeches and then we all clap in observance or commemoration of the day, such historic day, World Pharmacist Day. But the launch and establishment, of Dr. K's symposium is strategic. It's very strategic. This is going to last forever. It's going to leave an indelible imprint on our minds. And this symposium will serve as a platform that will keep all of you together, professionals in the society, engaging, researching, doing peer learning, coming up with new ideas and strengthening what you've already established. So I want to congratulate the Pharmaceutical Society of Liberia. I know Prof said that it's State Decoy Association, but we see Pharmaceutical Society of Liberia. I want to congratulate all of you. Thank you so much for thinking outside the box. I also want to congratulate the Ministry of Health. I will tell you not because I'm standing in their building, but Ministry of Health is doing exceedingly well. I'm saying it because I know it. Because I know it, I'm living it, I'm working with them. And the Ministry of Health, if you don't know, I was just in Addis Ababa 2 weeks ago. I was invited not to represent Liberia at the Africa and Caribbean Ministers of Health second edition meeting, but I was invited as a facilitator and a panelist to present Liberia's model of integrating health workers into civil service system, meaning bringing them into the government's payroll system. When it comes to that, Liberia is way ahead of many nations. Again, I'm telling you because we are doing it. Working with the Ministry of Health and working with the Ministry of Finance and Development Planning, we are bringing so many healthcare volunteers on the payroll. As I'm speaking to you, we have integrated more than 600 of them into the payroll. We received a week and a half ago 800 additional personnel action notices of volunteer health workers in different categories. And among them is the community health workers, that particular group. You know, they were being serviced and supported through grant, and I think UC was providing support to them significantly. Among the parents who received so far, we have about 300 of them that we are now reviewing and processing for payroll consideration. That is strategic because the situation was hopeless. UC withdrew, and there were concerns about continuity, sustainability, and that is why I would like for us to forge our partnership in a way that we start to think about the sustainability of many of the programs that are supported by donor agencies, by partners, so that we can take ownership as a government. It's our responsibility to address the health needs of our people. So those who provide the services, it's our responsibility to make sure that they are cared for. So we have to start thinking and discussing strategically to address these issues so that donor support can only be complementary. But our support cannot be complementary. It has to be the other way around because it's our responsibility to do that. Talking about integration, I am sure the pharmacists are aware that a good number of them were also brought into the payroll system quite recently, a little over 30, especially the intern, the doctors and the pharmacists directly. We brought some of them into the payroll. So I want to assure you that we will continue to work with you, and we have to work. We have to work. Yeah, that's the part of the music. And I'm sure many of you, when you saw me pass, you were like, oh, thank God, we need to hear what. But I want to tell you that we are going to also have another perspective of our engagement with Ministry of Health in a way that we create a pipeline so that it becomes somehow seamless. When you're completing your professional studies, then there shouldn't be trouble, Mr. President, in bringing the people into the payroll. We don't have to. So I will ask Doc specifically to take this message to the minister, and I'm open, the CSA is open and ready for us to engage so that our intern doctors, our pharmacists, and other people in specialized areas, we cannot keep them floating when they complete. We have to make sure that there is an established pipeline to bring them into the payroll system. Now you don't have to ask for it. You don't have to beg. Because it's your right as a citizen, as a professional, and you're dedicated to providing services to your country. The country must love you back. Having said that, I would just caution all of us in our professional capacities to engage constructively, because we need to understand that there are so many activities that the Ministry of Health and the Civil Service Agency cover. So many here, so we're engaging everybody. So sometimes when there are, delays, we need to understand that that doesn't constitute a denial or prevention, but it's just a matter of time. And that's why I want this seamless approach to be established so that it is natural and everybody knows where they're going when your processes are completed. We have to work on that. One conversation I was having with the management of the John F. Kennedy Medical Center was that, and we can engage on this and talk about it more. We need it for our healthcare sector was that we are not supposed to, again, sorry, people see me to be xenophobic when I make some of these comments, but I'm not. I'm just being nationalistic and looking out for my fellow compatriots. We have Liberians with equal potential that foreigners have. And foreign doctors come to provide services that we appreciate, but we don't live with that. We need to make sure that we provide more opportunities for Liberian healthcare professionals to specialize and to take over from these foreigners. And they take over from them, and they are in our country for a defined period. So we can't keep them here perpetually. Then the question is, how do we address the economic needs of these people who professionalize themselves, and then they can provide services, and we can give them what we need to give them. And so we can't keep having them perpetually in this country. We've talked to JFK to see, because it's supposed to be a teaching hospital, collaborating with, research institutes, the University of Liberia, doing more research, and then coming up with a timeline as to how long these people, we can keep these people, as much as we appreciate their services, but how long can we keep them in the country, and how many of our doctors are, undergoing specialized trainings, and how long will it take for them to complete, and how can we align them strategically so that if he's completing, as a specialist in the pharmacy field, and then he can take over from ex-foreigner who's a pharmacist, and we need to have a defined period, a timeline as to how long they can be here, and that our professionals too can rise, and all of them can realize the meaning of their citizenship and their service to their country. So we have to do that. And that doesn't just go with JFK, that goes with the Ministry of Health. So Doc, I'm just saying this so that we can start to have some of these conversations and not keep the people perpetually in the country, but have people to take over from them so that Liberians can take those roles. Sorry, but I'm a nationalist, and I believe Liberia 100% in every aspect of what we're supposed to do. And that's why I even think that, foreigners who have jobs and have work permits for jobs that Liberians are qualified to do should be revoked, and those jobs given back to Liberians. I think that's what we need. Let me tell you. And there's another side of the argument. I will tell you this. There's another, and that's not being xenophobic. Other countries are doing it. I will give you examples. There's another side of the argument that, we sell work permits and then we make more money. We mobilize domestic revenue, correct? But I will tell you that argument is easily defeated, because if you give the Liberian man or woman the job, you empower that individual, you empower the entire family, you empower a community. But beyond that, that individual is going to pay back to government in taxes, and the accumulation of the taxes annually is going to be far more than the amount the person will pay for a work permit. So it doesn't make any sense to give foreigners work permit for jobs that we are cultivating skills and knowledge for here locally, domestic. It doesn't make sense. We can give work permits for jobs that, are way up there that we don't cultivate the skills for. And even there is an agreement, the IMCC, that provides that over a period, Liberians should transition to take over from foreigners who have those jobs, quote unquote, high quality professional jobs that Liberians cannot do. So we need to get back and do our work as a country and put all of us back to work in this country and improve the economic standing of the individuals, the family, the community, and improve the economic situation of our country. We can do that. And you, the healthcare workers, you'll be in a better position so that you're not worried about whether or not you want to get a job, you're going to get on government payroll. It's your right. You have to transition the moment you complete your professional status. So today, I just want to assure you that the civil service agencies, you are invisible and strategic partner. Invisible because invisible because you don't see us. We are the ones who put you on the payroll. Ministry of Health processes you, but Ministry of Health does not put you on the payroll. The civil service agency puts you on the payroll and manages you on the payroll in concert with the Ministry of Health. That makes us invisible. It makes our role invisible because you don't interact with us except when you are angry and you want to protest. And before you come to see us, say, we got to see this director here today. You will not see him without going to the So, you know, I started hearing those things, and I know many of our compatriots protested, and I feel bad about that. You shouldn't manifest for what is your right. So today I'm really happy. It's a privilege for me. It's an honor to address you. And for the pharmacist sector, you know that I'm your friend personally. Sure. And you can get me anytime. So I'm happy to be here. And Mr. President, always as we do, my family and I are standing by. Anything we can do from that angle, we are ready. But from the civil service agency side, you're aware that that's one of the entities. We're not revenue generating, we don't make money. Please don't ask us for money or resources. Please don't do that. Yeah, but once we can put you on the payroll, I'm sure anytime I see you, I will see smiles and I will see happiness, and that's even better than us giving you cash or resources. Yeah, so I just want to thank you and congratulate you on this celebration. This is huge, and this is going to live for long in our hearts. Thank you.
You know, one group of pharmacists are very excited, more than everybody at the meetings. But our worry is transition. Praise God, we have the boss here, we have the minister here, we have pharmacy both. I mean, we are blessed because the message has gone. And we believe that we won't face too much problem when it comes to transition. Thank you. So at this time we turn to Prof. Silva and Prof. McLean to lead the aspect of the Archbishop's transition.
Thank you. So, hello, good afternoon. Hello? Thank you. I want to say this to you. Thank you, Pharmacist. You see, as a general, really spoke well and it touched our hearts. We are so happy. Well, now we are happy. Now we are about to go book. We are going to book. Now it's time for book, right? I remember Professor Pierre, if I just do a second, he said, "Oh, sorry, I'm depending on you. I'm depending on you, okay? No, he's going to go. I'm depending on you." Then he will call you in the middle of the night from 10 to 5 a.m. So I said, "Bro, let me just call you." No, just give me a minute. I want to show you something. And mind you, I'm giving a presentation tomorrow, and he's there. So everybody knew him for that. But he was a wonderful professor. And that's a big thank you to our mom for keeping it up. So, ladies and gentlemen, I want to do an abstract presentation, and I'm here with my co-presenter, Professor Dr. McLean. Please come and go see her. Thank you. She will not keep the time. Now, with all the remuneration fund we are talking, with all the visibility, with all the goodies, look, pharmacists are very sophisticated, very complex, and they least utilized in the healthcare system. Whether you like it or not, I hate when people say pharmacists are not just dispensers. Gone are the days of dispensing in pharmacy practice. Pharmacists are integral, key members of the healthcare team. Pharmacists are specialized in oncology, internal medicine, and other areas of para and traditional orthodox professionals. So we don't keep pharmacists down anything. But the thing is, as you are talking these things, you yourself, as somebody watching your back, you should be watching your stomach. So we hope to get involved into research that will lead to innovations. Now, we have few studies that have been done. Some of these studies will be recorded, some of them will be repeated, some will be now a prospective or what kind of study. But we have few studies now that we want to. Okay, there are a few studies here that are being conducted and we want to display. Now, pharmacists, you have a key part to play in the healthcare system. You are not just members of the healthcare team, you must engage into research. You can't keep talking money, and you are not talking about filling the gap, and you are not talking about identification of gap. You can't, I like to see things from different angles. You can't keep talking, you must raise her up, but what have you to show? There was a time during Ebola when a clinical pharmacist recommended to a physician, he said, let's use the 3TC in this particular condition. It will work very well. Imagine, when that particular physician followed the pharmacist's advice, increasingly the pharmacist did not document it. Lack of documentation is suffering us. There are so many interventions that have been done by pharmacists. They are not documented. So in this time, not to take up more time, want to do the abstract presentation. You know, abstract is the executive summary of a piece of work, right? Where you find the whole work is summarized. So our first presenter will have 10 minutes, and the first presenter is nobody different than the president of the Pharmaceutical Society of Liberia, Dr. Joey Kekula. Somebody's
I don't know how we're related, but when you see my hands on it, you should move. Okay. Yeah. Thank you so much, guys. We are happy now.
Time starts now.
I can't start like that. I will do within just 15 slides, within just 10. So we are happy for this activity. We're going to be presenting to you on this topic, medicine system monitoring. The strategic approach in the fight in sustainable falsified medicine in Africa, Liberia approach. How are we really different from other countries? Next. So my outline follow the pattern that we see. So these are abbreviations: sustainable falsified medicine, adverse events, and the rest of it. Definition is key for me to just emphasize one or two things on this definition. It's very important for me. Sustainable falsified medicines are those that do not meet the quality standard and specification. The quality standard and specification. What is specification on that particular medication? Okay, often due to poor manufacturing or inadequate quality control. An example would be an anti-malaria medicine with incorrect or insufficient amount of API, active pharmaceutical ingredient. Falsified medicine means when someone deliberately manufacture or misrepresent an identity, composition, or source. Alright? And the rest, okay, then medicine system monitoring pharmacovigilance. Adverse drug reaction is part of adverse drug event. So adverse drug event, adverse event is a global, let's say, ADR is a subset of that. These are key things that you need to understand as we go through the presentation. Next. So, sustainable falsified medicine create a devastating burden by causing treatment failures. And that is why it's important that we talk about this, because normally as we go down we see details of that. It worsens illness, it leads to death, particularly in vulnerable population and children all around the world. So the major statistics we have 1 in every 10 medicines in low to middle income countries in Africa, around the world, are sustainable and falsified medicinal products. Of course, it can create a health burden, economic and social burden. So medicine system monitoring complements post-market surveillance. At the LMHRA, the Liberia Medicine Health Product Regulatory Authority, is a competent body that regulates all medicinal products in Liberia. This includes the fight against sustainable and falsified medicinal products. Next. So how are we combating sustainable and falsified medicinal products? The traditional method of combating these requires primary inspectorate, regulatory oversight, legal framework, physical inspection to detect sustainable and falsified medicinal products. PV approach is crucial as it complements both traditional and non-traditional strategies in combating sustainable medicinal products. It provides a reactive layer of defense by gathering and analyzing real-world data after products have been qualified and entered the market into your facilities. It provides crucial post-market surveillance data that can help detect sustainable and falsified medicinal products that sometimes slip through regulatory and supply chain and enter the health facilities. Next slide. So how do we combat substance and falsified medicine? There are two approaches. One is traditional, one is non-traditional. The traditional approach talks about getting the medicinal product, conducting physical and visual inspection. For those of you that are not in the regulatory field, physical and visual inspection, you look at the medicinal product, you look at the expiry date, the batch number, the manufacturing address, and all of this information. You send sample to the lab to test to see if they meet the standard that is set. If it's 500 milligram, whether that API in that product is 500 milligram or less. Of course, public campaign awareness, that is creating awareness around substance and falsified medicine. You must have a legal regulatory framework to do this thing when it comes to non-traditional. The non-traditional approach has to do with the track and trace system. In fact, as a matter of fact, LMHR is now putting into plan to begin to improve that system. The smart packaging, authentication technology, portable analytical data. Sometime years back, LMHR had the TrueScan that they were using. So these are artificial intelligence. These are the two approaches that you use in combating substance and falsified medicine. Where do we come with PV? Next slide. So the PV activity contribution, let me go to the fight. Our drugs event or drug reaction or lack of therapeutic effect can be a major indicating factor. Therapeutic failure report and ineffectiveness report is one of the most early signs of substance and falsified medicine. So in your facilities, whenever there's therapeutic failure, you just don't look at the road of administration or how was it administered, where all of that. Also, it's important that when you are looking at all of that and you have to receive a good check on the product quality, because that's the last place that you want to find more detail on. So signal detection and data analysis. So when we talk about signal detection, it's like maybe there was this paracetamol, let's say doing more, that was distributed in LOFA, in Womi, in River G, and other areas. If you start to see people complain about that same product in all of the three areas, that is signal that indicating that there's something wrong with that particular product. Next slide. So what are our materials and methods that we use in conducting the conduct of this particular experiment? We carefully analog activities of ADR report collected data, analyzing, interviews some victims and documents that are related to some of these programs. So one of the key ones I thought to pull out in this particular abstract as well is a signal that we received years back. It's just a case study about one of these. It's a falsified fetal baritone. Now reported from Liberia at one of the hospitals that lacked treatment, they led to treatment failure. And you know what fetal baritone is used for. Now if you see a patient a group of patients with one particular product, and all of them that took that particular product, they started having relapses. In fact, mental health colleagues here talk about it, sometimes we discuss it. So because of the relapses, it created greater attention. We went into that to research and review. And if you want to find more detail about that particular phenobarbital, you can Google this particular reference, medical program, and that is a WHO publication. You Google now, the whole story will come out there, publication still exists. Next slide, almost done. So, discussion and review. So with this part, the limited financial resources and expertise in analyzing, the system monitoring approach, and nonetheless succeeded in making significant strides in combating substance and falsified medicine. Increasing reports will help us to make regulatory decisions on some of these products. But if we have this kind of cases, but I'm reporting it to the LMHRA, definitely we wouldn't know, and people will continue to suffer from such products. Next slide. So in conclusion, medicine system monitoring is the last approach that enables the healthcare professional and patient to report suspected cases, which can enable regulators to take appropriate action, sometimes program recall, and we encourage all health practitioners, including you, the pharmacists, especially to really make use of this process. It will help us with regulatory review. Capacity building with the GHPP has helped us in most of our work to to raise up our still early investors in this situation. Next slide. I want to thank all my colleagues at the delegation already in the Port and Institute. I work along with us to produce this particular document. References are there. So thank you. We look forward to the question now.
Thank you, Dr. Kekula. That was brilliant. Okay, I know that you have questions, right? So all you have to do for each presenter, just jot your questions or comments, and then they will come up here at the end for about 15 or 20 minutes, and we ask them. It should be interactive. So the next presenter will be coming up. The next presenter will be Dr. Adu when you are ready. Now, this is how your retreat, your annual general meeting and scientific symposium is going to be. So all we want from you, just do stories. Send in your abstracts. Come and defend your abstracts. All right? We are pharmacists. We are people of academic background, highly educated. We shouldn't hide it. Okay? We are encouraging you. The message went out, and I think only 3 persons sent in the abstract. Some said they didn't know. But no worries. By when will be the next one? December, right? By December, I'm sure most of you will be exhibiting your intellectual powers. So, are you ready? The next presenter will be coming up speaking on the topic implementation of AMR surveillance program in Southeast Liberia. So we say the journey so far. Ladies and gentlemen, let's welcome Dr. Emmanuel Agu. So what you want to do, she will signal you when you have about 3 minutes left. When he has 3 minutes left, when you have 10 minutes.
Thank you. Actually, I was not actually informed as timing when I was preparing the presentation. So actually, the presentation to cover that 10 minutes. So I'm just explaining.
So take the main slides. As you go in, if you don't want us to go to that, just check.
Yeah, the one this or not. My presentation, I want to use this presentation. I want my students to use it as a tool, not to share it as a tool.
So the knowledge will be 10 minutes. If I were you, I would let the group below 10 minutes. All right? We don't want the mic to go off on you.
Thank you. So this is the presentation from Southeast Liberia, specifically Tree Hospital, J.J. Dawson Hospital, Garrison, and Fishtown Hospital in Milwaukee County. Please, can you go next?
Next. Just the next one will go.
Next. So can you go to the, okay. Alright, so this is the outline. We were talking about introduce antimicrobial resistance, stewardship, perspective, etc. Please, yes. Oh, what you talk about something? Anyway, very good. So you have there's a study that was published this on Monday by a CDC researcher, and Tony Wise read this. He stated that we have a bacterial network that almost between 2019 and 2023. You have resistance rate of that bacterial network to be 70% between 2019 and 2023, and you have this NDN gene, this Australian gene that this bacteria is carrying, and because of this, you have cases increasing now in the United States. So this study was published this September 2025. So I'm sort of concluding it, and it shows that antimicrobial resistance is on the increase. It's something that we have to look at and see how best to tackle, because we are the health worker and our patients look up to us to solve this problem of the diseases. So this is it. Please, next slide, please. And we know that microbial resistance has to do with when bacteria or change forms or DNA structure to fight against the antibiotics that we use to treat. So, calling up resistance, when the bacteria call up resistance against the antibiotics, we say that is microbial resistance. And they strengthen our health. And it's not only locally to Liberia, but the entire world business. So stewardship, antimicrobial stewardship has to do with coordinated intervention, where you have a health team, not only pharmacists, you have different health professionals, doctors, etc., working together to protect bacterial resistance. That is, when you are protecting bacterial resistance, you pass out education to caregiver, you pass education to patients, you tell people how to use antibiotics. And we are concerned of the medication, we are pharmacists. So we have to put in more to tackle microbial resistance. We have to put in more to act as stewards to this project. Please, next. How the world sees microbial resistance. There is a threat to the world, and AMR is among the first 10 top diseases according to the WHO that humanity is facing now. What causes AMR? We all know that misuse, abuse of medication, in our various hospital or clinics, our clinician or caregiver are not prescribing the actual doses. There are so many factors that give rise to microbial resistance. So, from the O'Neill study, it's been projected that if nothing is done, when we just sit down and relax, nothing is done to tackle microbial resistance from now to 2050, we'll be losing 10 million individuals. So, our family, our brothers, our sisters, our children will be part of that. So, we ourselves will be part of that. So, it's a need for us to start working now before 2050. Please, next slide. Next slide, please. My time. Next slide, please. So, this project was introduced by GRZ. GRZ partnered with the MOH, partners in health. Fortunately, we are assigned there. I was assigned there in 2018. We received a series of training. Some of us we've been connected with so many webinars, so that we get this antimicrobial information. So GRZ came to support the health system of Liberia, and this is kind of a gift to the Liberia health sector to come up with this pilot project. The project was done in 3 hospitals in Southeast, as I said earlier, in Maryland, in River G, and in Franklin County, the government hospitals there. So we have objectives of this program: surveillance, to carry out surveillance is one, to develop stewardship, and to make sure to give our patients the actual antibiotics that we're supposed to receive. Please, next. So this is a diagram of the place that this study took place. Please, next. So this is the structure. So as I was saying, in our very hospital or facility for clinical pharmacists, those are our leg for, I really want the clinical pharmacists to put in this. You can have the structure like this. This is actually the old one, the leadership before. I know that there's some changes in this leadership. Pharmacist Diana is not the chair again. We have pharmacist Silva, Dr. Silva, she's the chair person at Central. So we have at the national level steering committee, and we have a steering committee structure at the county level. So in our various workplaces, we can structure this. CSO is part of this team, and the pharmacist play a key role on this team. That's the reason why I want the pharmacists who are in clinical practice to make sure to introduce this project at your facility. Please, next. Roles and responsibility of the steering committee. Talk about prescribing the right antimicrobials. We carry out hospital war rounds. We have scheduled war rounds. The entire team, not only pharmacists, but pharmacists should lead because this kind of do with prescribing antibiotics. Please let me know. Next. So we have private diseases. When doing this, we have private diseases. We have 5. We have meningitis. We have skin soft tissue infection. We have acquired pneumonia. We have urinary tract infection. We have obstetric gynecological infection. So all these are diseases. We take specific samples to the lab for these diseases. Okay, so while in the study, we come up every year. We come up with a guideline. Every year we come up with a guideline, and this is the 2021 guideline that we created, and so this is the 2021 guideline we created. We have a 2020 version, and after the study from 2019, the study started 2019, we created our guideline 2020. Then we had a 1 year interval. So after 2021, we jumped 2 years. We have the recent one, 2023 guideline. So this is about, how we got this guideline from the local susceptibility test from our lab, where we took sample and we carry on the culture and sensitivity test. We studied the antibiotics that are susceptible to the isolates that we see from the lab. That's how we come up with the guideline. We also visited other areas from the world. We visited our therapeutic guideline of Liberia as well. Next. So these are the contributors. I think that 2 Liberians, me and one of my colleagues, are contributors to the guidelines. And next please. Okay, this is the form we use, and this form is approved. Doctors recognize this form. When you go to the hospital, it will be used as a tool to recognize our role in the period of assigned period. Next please. Wow. So these are preliminary results from our study. So from the 3 hospitals.
Let's summarize your findings.
So from the hospital we have, can you just put the result? Let me just summarize the result. So for the 3 hospitals, the samples that were taken for the 3 hospitals, we had a total of, the preliminary results, we had a total of 860. And as you can see, we have GKT 45% of the sample. We have Raritan and we have Fishtan. And GKT had the highest. Then these are specimen analyzed from the microbiology lab. Then we have types. These are the types. We took from UTI, skin soft tissue infection, blood infection, GI, lung, etc. Please get Then we separated the gram-negative bacteria or macro from the one gram-positive. I think as you can see here, we had 245 gram-negative separated, and we had 90 gram-positive or macro separated. And you can see their names, their various names: E. coli, Pneumonia, and P. or Uruginosa, and etc. We have them separated. Please next. Then what we the resistant pattern of the bacteria when we did the culture. You notice that ampicillin, most of the aspirin were highly resistant to ampicillin. You see the comparison of the antibiotics here. 85% of the isolates were resistant to ampicillin. As you can see, this is the trend. So we have various antibiotics we use against the isolates, and this is the result. Please next. So this is an overview of commonly prescribed antibiotics. We notice that ceftriaxone from the study, ceftriaxone have a higher rate, resistance rate, and then for metronidazole, and as instead respiratory. Next. So the objective of clinicians, because you have a team, you say what the objective of clinician of the recommendation of the necessary committee member, how the clinician accepted the team, because you are there to provide education to the clinician, those are giving the medication to the patients. So the uptake, you notice that 85% of the clinician accepted it. So this is it. Thank you. So thank you.
Hello. So when you attend these kind of programs and give you the time, you see how they call it back off for you? Yeah, you're laughing at you see, when you are really getting into the state now. You're just talking about hearing you again. Actually, it's a beautiful piece of work, and I know questions are out there. We have questions waiting. When you come here, when you will be coming up to present next time, look, we will give you the guidelines. Honestly, the guidelines were not given. So, you can't blame our people. This is something that we are testing the Itaquaki scientific seminar, and then it will go better than this. All right. Now we are about to go to the next, the last presenter.
Quick announcement, please. Our red jeep is marking away with the number E525527. So if it is yours, please go and get out of the way.
Okay, one jeep, blocking the way. So, ladies and gentlemen, I know you are sitting over there, pharmacist students, interns. You have papers. I know I can call some people and say, come to present the papers now. Okay, but that is not the time. This is not the time for it. Look, we have so many good things. He just presented on antimicrobial resistance, and then we have questions because I know that some of these things, some students here or former students have done it before. Now the last presenter is coming up, and that is nobody else but put your hands together and welcome Reverend Dr. Professor Liberia has been blessed. Now that we have Professor Asifa Tabe, we had Professor Tinsley Tatita, former president of the OEDCB2. You can imagine how far we have been blessed. Thank you, Professor.
Thank you. Because I am from academia, I will be straight to the point. And so this is the topic we are assessing antimicrobial prescribing pathogen here from Memorial Hospital. Next slide. This is background. Antibiotics have gained global attention because of its misuse. And the inappropriate use of this very important medication has claimed our attention. And so, there being an institution that has diverse practitioners, so yes, there will be an area of the next slide. What method we said, we employ a descriptive cross-sectional survey utilizing with paper data. Our convenience sampling method was utilized to recruit our participants. Data analyzed using descriptive statistics with frequency, and percentage where the value of 0.5 was asked. This is the PNL. Next slide. Before I conclude this, let me bring me to Kono, who helped me. This is the paper that I did when I remember found the paper. And the respondent, we have 70% male, then 30% female. Next, we have the result. The category of prescribed tapping in it, medical doctors, followed by pharmacists, which we may not have been aware of, then physician assistant, nurses, and dentists. Next. For clinicians, the unit, we look look at the different between where description, whether these are the numbers, and they speak volume. Next slide. We look at the drug trafficking community, where they have drug trafficking community, and you will see that that institution of that caliber, they not have drug trafficking community, which is critical in policing the use of medication. This is what it shows. Next slide. Then we have the ability formulary and adhering to guidelines. Where they were adhering to guidelines. These are the fields that are portrayed that grasp is adequate adhering to guidelines. Next. Our conclusion. And the conclusion is a lack of formulary and hospital trafficking, or you call drug trafficking community in that complex. Continue to proliferation of antimicrobial and more patients. How it is recommended from this research that DFA department, the economic department, be able to develop all of the guidelines that will put into place all the necessary tools. Because when we fail to do this, it implies those antimicrobial incident, major killer of the day. I think that does it with my first and the next. Okay, these are the references. And let me make emphasis, fellow police, I am happy to be part of this very inaugural, program in honor of my professor, my kinsman. I always say people from the Southeast, they are wise people.
That's it.
Here was a wise people, demonstrated wisdom everywhere they went. And I salute him, and I will continue to salute him throughout my life until life is. So that's all. God bless you.
Could you give a round of applause for now, our presenters, we want to ask you to come up here, please. Our presenters. Now, I know that you have questions, comments, so we may have 15 minutes for Q&A, comments. All right? Now that I know that you have enjoyed the presentation, strictly to the point. So, this is the beautiful abstract presentation. Now, I want to turn this time over to Professor Dr. McLean, who will recognize the question here or the question people. If you want to say. Only 15 minutes to that.
So our time starts. If you have a question, you just let me know, and I'll bring the mic with you. Do we have anyone in the audience? Were we paying attention? I think there are some key things that were said today, and we want to ask some questions. Okay. Okay.
All right. Thank you very much, President, for the presentation. It was so nice. Our question has to do with the measure being on the presentation concerning about quality control and also drug efficacy and potency also the measures. I want to know what measure will you put, what will you wait for those that are in the habit of misuse of drugs, or this dispensing of drugs, especially those that are beyond the counter, those that are not reaching up to standard, which is the next pillar. What would be the mechanism put in place to implement standard? That's my question.
Thank you. My name is Arthur Loyan. Before my question, I want to make a general remark or statement briefly. And what I observe here is that I think we need some orientation if we are to make progress in this worthy initiative. But so that all of us can be on par how to organize the research, presentation, and what have you. There is no effort or attempt to undermine anybody's effort here, but all of us are students, we are still learning. I think if the leadership can organize in the future, that we can have some training section specifically on research, discuss the various components of the research work, so that 3 years from now, we can reflect on this very day, how things was like, and compare what it will be 3 years from now. My question is, Prof. Tani, when you are mentioning the results, the data on your work by the prescribers, I saw 40% doctors and the rest was pharmacists are the nation's highest preferred hospital. My question is, do we have any policy in place there that gives the authority to pharmacists to do prescription? I know this is a thing that we've wanted for some time. For time now, when pharmacists talk about prescribing, all people have like, what is he talking about? And if that is not in place, what can we do to make sure that that is institutionalized across our health sector can move forward so that pharmacists feel comfortable to do what they want to do? Thank you.
Thank you. We have 3 more questions. We have people with questions, and your question can go for at least 30 seconds, please.
I'm Dr. Jimmy D. Carter, Intern Pharmacist, GFK. I want to speak specifically to the topic antimicrobial resistance. So, Dr. Egu, you discussed antimicrobial resistance in your research. I didn't hear you mention culture and sensitivity tests. What is the importance of culture and sensitivity tests in respect to antimicrobial resistance?
Thank you, everyone. I'm Dr. Stephanie from GFK, I'm a chief pharmacist for GFK. My question goes to Professor Tai. When we took over from GFK, we realized that we never had the Standard Therapeutic Committee. So when you mentioned that, I thought it was going to be coming. So right now, we have the Standard Therapeutic Committee in place. And as a matter of fact, our microbiology now will be up. And key to that is that we'll be doing our CMS, making sure that prescribers prescribe the right antibiotics for our patients so that we can get or add to the already public health already of antimicrobial resistance. So the first edition or the first formulary for GFK Hospital will be up by next year, and that will be the Standard Therapeutic Committee program. Thank you.
30 seconds, please.
Dr. Bobby Andrews, the Chief Pharmacist at the Center of Infectious Diseases. My question goes to the 5% thought on the pharmacovigilance aspect was the push. I just want to introduce us to the research method he brought with his study. The research method.
Thank you. And we will look up for one question. Yeah.
That is, what implication is he trying to bring to our mind if he's talking about the assessment of antibiotic to that of male and female at the JF?